Once daily Forxiga, dapagliflozin, for patients with CKD with or without type 2 diabetes. In patients with CKD, increased pressure inside the glomerulus can lead to a decline in kidney function. Forxiga slows kidney function decline by reducing intraglomerular pressure. Forxiga helps to lower pressure by reducing blood flow into the glomerulus. This renal benefit is not dependent on the blood glucose lowering effect of Forxiga and is not limited to patients with diabetes. The Forxiga mechanism of action is complementary to that of ACE inhibitors and ARBs, which increase blood flow out of the glomerulus. Treating with Forxiga can help slow the composite of declining kidney function, end-stage kidney disease, and renal or CV death in comparison to placebo. In addition, Forxiga reduced the risk of death from any cause versus placebo.
This is for scientists and those who believe in the potential of science. It starts with curiosity, a surprise in the pattern, an obstacle that can't be explained. Step by step by step, they challenge, explore, and unlock the unknown, fueled by imagination, alone and with others, repeating an experiment 1,000 times to have the chance to get it right. Once, but for forever. Making brave choices, choosing to push the boundaries, and choosing again and again to be led by science in everyday decisions, everyday interactions, no matter where they are. Because putting science at the center of everything is the best way to understand and transform disease, the best way to change people's lives. This is why we believe in what science can do.
Once daily Forxiga, dapagliflozin, for patients with CKD with or without type 2 diabetes. In patients with CKD, increased pressure inside the glomerulus can lead to a decline in kidney function. Forxiga slows kidney function decline by reducing intraglomerular pressure. Forxiga helps to lower pressure by reducing blood flow into the glomerulus. This renal benefit is not dependent on the blood glucose lowering effect of Forxiga and is not limited to patients with diabetes. The Forxiga mechanism of action is complementary to that of ACE inhibitors and ARBs, which increase blood flow out of the glomerulus. Treating with Forxiga can help slow the composite of declining kidney function, end-stage kidney disease, and renal or CV death in comparison to placebo. In addition, Forxiga reduced the risk of death from any cause versus placebo.
This is for scientists and those who believe in the potential of science. It starts with curiosity, a surprise in the pattern, an obstacle that can't be explained. Step by step by step, they challenge, explore, and unlock the unknown, fueled by imagination, alone and with others, repeating an experiment 1,000 times to have the chance to get it right. Once, but for forever. Making brave choices, choosing to push the boundaries, and choosing again and again to be led by science in everyday decisions, everyday interactions, no matter where they are. Because putting science at the center of everything is the best way to understand and transform disease, the best way to change people's lives. This is why we believe in what science can do.
any red dots, there's some behavioral activity that's associated. So just poke and then see where you find yourself. If you poke and it pokes the heart, it means that there's something that is troubling the heart and needs to stop. If you poke and you poke outside the heart, then it's a safe practice. You can continue. It's a simple exercise just to see where you belong to. So if you poke about 3 or 4 and they are all punching the heart, you should know that the heart is already gone. So it's something simple I wanted. So I think this under the kind auspices of Shalina Healthcare Services. So it's something I want us to do this morning. So just poke. You can poke all of them and see, or whichever applies to you as a matter of fact. And then let me know how your heart is faring. Thank you. Okay, so I'll probably come table by table and see how you are doing. Oh, you did yours yesterday. And how was it?
There was one hole in heart.
Okay, so this is acquired hole in heart, isn't it? Okay, so it means it's preventable. When I come to your table, you tell me which behavior you identify with and how it impacts on heart health. Uche.
I have poked 4. No, I poked 6 actually, but 2 are outside and 4 are in.
Okay, so you have 4 in the heart. 4 in the heart.
Unfortunately, I'll try and reduce it to 2 at least.
Hello, can I please have some volume? Hello, hello. Thank you. So 4 is a lot. Which ones do you think are immediately remediable?
I think the junk food and then trying to exercise. I think those are the 2 easy ones.
Good. So exercise is important. In fact, the World Heart Federation and WHO are advocating enough exercise. There's evidence to show that if you exercise for at least 150 minutes in a week continuously, you prolong your life by 1 hour. So those of you who want long life, exercise continuously. How many pokes do you have on this table?
2.
Okay. And where are we? In or outside the heart?
Within the heart.
Hey. This is a cardiology forum, and people are staying in the heart. So which ones do you think are immediately remediable?
Making time to exercise.
So exercise one more time is important. Okay. Who do we have here? Please poke before you turn and see if it's poking the heart too. Don't and poke from behind. So how many?
So far I have 3. Yes.
Okay.
And they are all inside the heart.
So this is Azo. With all the insight and information, we are still in the heart. It means those without, we have a lot of work to do. Which ones do you think are immediately, or at least in the short term, remediable?
I've decided that now I have to be doing some brisk walking every evening, or maybe 3 times every evening.
Okay. Anyway, there's evidence to show that brisk walking also equates and benefits. So it's in order. But it appears exercise is really dominating so far. All right. Menka, how many did you poke? And as I said, make sure you poke before you check.
4.
Okay, and out of the 4, how many?
Only one pokes.
Okay. And which one poked the heart?
I find life in general has become quite stressful.
Okay. Okay, so it's about stress management, isn't it? Okay, so have you identified which is the chief driver of stress for you so far? Have you? Otherwise, I can go and come back.
Work.
Okay, so it means, but unemployment itself is more than, enough stress. So.
Too much work too is also another stress.
So we need to strike a balance between the two. Okay, all right.
Are you asking me whether?
Okay.
This is quite a fascinating exercise. For me, basically life has become generally stressful. Okay. Yes, and I want to exercise, but I don't have time to exercise. Okay. I think the latter I can redeem later.
All right, thank you, Prof. So exercise and stress appear to be topping the chart. We may have to plan something around exercise and stress. Okay, I'm coming to the very endowed table to see how endowed our hearts are. I'll start with the maybe younger folks first. Yakubu, so how many did you poke? Or none?
3.
Okay.
Poke to the heart twice.
Okay. And which 2 things did you poke in the heart?
So I want to exercise, but just don't get the time.
Okay. So exercise once again.
And then find life is quite stressful.
Hey, stress and this lack of exercise. Jifa, I think incoming executives, we have work to do on stress and workload. Okay, now, Dr. John, before you deliver the... You have it. Okay, I'll spare you. Yeah, I'll come to... Dr. Fugu, okay. How are we doing with the heart?
I poked the heart once, and I want to exercise, but I don't really get the time to exercise.
All right, thank you. So exercise. I think now I'm more than convinced, because if we look at the sample size and the numbers we are getting, it will be significant. Dr. Mable, you did yours yesterday. Okay.
Interestingly enough, I didn't poke the heart.
Oh wow! Shall we put our hands for Dr. Mable? And this is enough resource right here for our CPD. Yes, he will tell us how he's done it over the years. All right, a few more tables, and then I think it's almost 9:30. So, IT, let me know when you are ready with the slides, and we can take off. But 2 more tables to go. Madam Esther, how many pokes and how many hearts?
5 poked, but 3 in the heart.
And the 3, which are those?
I enjoyed watching television late in the night.
Okay.
So I think I have to stop because I need more rest.
Okay, and the others?
I want to exercise, but I just don't get the time.
Okay, and the last one?
As much as I want to, I can't resist junk food.
Okay. All right, thank you. So diet is the third one that is lacking its ugly head, in addition to exercise and stress. Now, this very, should I say, semi-table, how many pokes and how many in the heart?
I think virtually it's the same. I poked the heart once. I want to exercise, but I just don't get the time, virtually.
Okay. And then the other. Oh, you poked it once?
No, the heart once.
The rest were outside?
The rest were outside, yeah.
Okay. Thank you. So exercise. Did you poke? Not yet. Okay. Then be poking. I'll be back. Did you? Okay. So far, exercise and stress. Now the last table, in fact, if exercise features here, I'm sure CPD is sorted for next quarter. How many did you poke? How many inside the heart? I'm not interested in outside the heart.
I poked 4, 2 in the heart, 2 outside. So I do have some fat around my belly.
Okay.
And I find life in general quite stressful.
All right. So I think the two are not unrelated, meaning they are related. Stress and truncal adiposity. Not so. All right.
Okay. I also had 4 pokes, 2 in the heart, 2 outside the heart. The 2 in the heart were, I want to exercise, but I don't have time. I don't get the time. And I find life in general has become quite stressful.
Okay, so I think the next exercise will be to collate how many people find life stressful and see if they are more resident or more consultant, so we can see how to fashion our solution. So, Jiva, take note. Thank you all very much for indulging in this exercise and the findings. I think without delay, we should launch into today's program. Where is my co-moderator, Abba? Okay, Abba cannot be found. But our chairman, who I have to introduce, is not new to us, not new to presentations, not new to chairing programs. She is a pediatric cardiologist with a vast array of experience. I'm sure time would even not permit us to go through her CV. Suffice to say that she is working as a pediatric cardiologist and is a professor professor at the University of Cape Coast, Professor Nana Echa Yao, right? Thank you very much. I'll put our hands together for her. So you chair, so you'll be here, and then so she will handle the next session as the chair person. Thank you very much.
Good morning, everyone. I'm glad you made it out of bed and you're all here. Today's session promises to be very educational, and I'd like to welcome each and every one of you. Without much ado, we won't waste any time. We want to invite to the podium our first speaker, and I'm very honored and delighted to introduce a friend who is as well a professional colleague. He's a seasoned adult cardiologist all the way from Sierra Leone, and he's also the Dean of the Faculty of Clinical Sciences in Sierra Leone. I'd like you to welcome our international speaker, Professor Russell, to speak to us this morning about cardiovascular assessment.
IT, are we ready or not yet?
A very good morning to everyone. I'm very much delighted to be in Ghana once again for academic-related activities, especially so when we talk about cardiology, as I've always been honored and extended invite from academic institution. Before I proceed with my presentation, I would like to express my sincere thanks to the President and members of the Ghanaian Society of Cardiology for inviting me as a speaker. And this time around, I've been charged with the responsibility to talk on cardiovascular risk assessment in women. And honestly, I'm elated, because this is quite an interesting topic wherein it forms the fundamental bedrock upon which you should be practicing on risk-related factors. Thank you very much for the invite. Lady Chair, due to the enormity of this presentation, please permit me if I overshoot against my allocated time so that I can do justice to the presentation. I have absolutely nothing to disclose, and the scope of my presentation will comprise of a brief introduction of the topic. I'll provide a framework of scientific evidence related to the review of the risk that is related to women. And thereafter, we'll talk briefly on the risk stratification tools that have been validated in risk assessment. And I'll take a message on my concluding slide. Women are completely different from men, not only in their genetic makeup as well as their sex hormones, but also the way we stand in front of the mirror. And it is telling from this slide. And you can see that a man can stand in front of the mirror fist on, whilst a woman will be standing trying to look at the mirror but with her back. And it is even telling from the way we communicate. When a man says hi, it's just simple hi. But when a woman says hi, think twice, because it is loaded. And it means so much more than I. These two slides, in the form of a cartoon fashion, describe and differentiate what we've been talking about all this while about sex and gender. And these are words that are frequently interchanged. But in cardiology, gender is gender, sex is sex, because gender and sex can influence the outcome of cardiovascular risk in women. If we can go further, sex matters in medicine, especially in cardiovascular medicine, where women have been marginalized for such a very long time, particularly in public health-related research. And this has resulted in the gross underestimation of sex and gender-specific related risk factors of cardiovascular disease. Having said that, the Lancet Commission for Women and Cardiovascular Disease tried to postulate reason for this gross underestimation of the sex and gender data related to cardiovascular medicine. And they postulated that cardiovascular disease amongst women are understudied, under-recognized, under-diagnosed, and to some extent, women are less represented in clinical trials. And it is so true until recently, when the Women's Health Initiative and other health research institutions increase our scope of understanding of what it takes about cardiovascular medicine in women. And to date, 1 in every 3 women will die of cardiovascular disease. And in 2019, it has been shown that 295 million women were diagnosed of cardiovascular disease, and 8.9 of these actually died. The question is, the gap between women and men related to cardiovascular disease is as old as the head of Methuselah. And you can see that along the way, there has been a significant decrease in the mortality outcome for men, unlike that of women. And it was only in the early parts of 2002 that due to the initiative of National Health Campaign, that we saw a significant decrease in the mortality of cardiovascular disease amongst women. Taking a closer look at Africa, what is actually the picture? And in this editorial that was published, it clearly states that cardiovascular disease is a growing threat in Africa, and the mortality associated with it is as high as 9.2%, with a disproportionate effect on young women as well as women. So, what is this business of us sitting here listening to my voice on issues related to the assessment of cardiovascular risk in women? It is believed, and it has been documented, that most women, by the time they visit their health practitioner, significant proportion of them already have multi-risk factors, unlike that of men. And it is also believed that significant proportion of women basically cannot communicate their symptoms adequately to their healthcare providers. Why is this so? Are we not actually listening to our patients, or are these women not in a position to explain themselves because when they say hi, you have to think twice? And maybe that's the way we practice medicine when we are confronted with women's consultation. As a result of this, we realize that in our practice, we seldomly evaluate our women as extensively as we can when we assess our male counterpart. And due to the long delay in the diagnosis of these women, a significant proportion of them will die suddenly. And these are some of, in the schematic diagram, some of the ways and explanation that have been given related to the sudden death seen in women. And this is also responsible as to why cardiovascular disease is the #1 killer in women, and it kills even more than any other combined cancer-related disease. Having said that, I spoke to you yesterday about the evidence which are available, the VAGOS trial, which was actually conducted amongst young patients who had chest pain. And this study clearly shows that when health professionals were asked about what were their thoughts about the clinical presentation of the women presented with chest pain, a significant proportion of them thought that it has nothing related to heart disease. And you could actually see that most of these patients were actually referred elsewhere. Some were referred to psychiatrists, some were even referred to obstetrics and gynecologists because they thought that it might be related to perimenopausal symptoms and postmenopausal symptoms. And sadly to say, I believe a significant proportion of us seated here must have been a victim wherein we just say, this is perimenopausal. You go and find what else you can do. But when this study actually looked at the response related to women, you can clearly see that a significant proportion of the women thought that, well, they've been told that it's related to anxiety. So they thought, yes, it could be related to anxiety because that is the message we are actually passing to our female patients. And as a result, they were asked why did they actually visit these institutions. A significant proportion thought that they had heart disease, and some of them thought that they had diabetes. So the question is, should we be blindfolded when we are examining our patients? That's the question I'm actually leaving to you, so that we cannot be biased when we see female patients in front of us and we want to assess their risk-related factors. So what is this business of cardiovascular assessment? It is imperative to note that we should understand the basic science that is responsible for the worsening outcome of cardiovascular disease so that we can strategize in terms of planning. And this slide has been shown over and again. And it is a slide which basically classifies cardiovascular risk in women in 3 conventional categories. We have the well-defined risk factors, which is common between us. And these are also referred to as the traditional risk. But we know that women were created in the image of God. And women are fearfully and wonderfully made with special interest from God. And that's why they were given special additional risk factors which are extremely unique to them. And we men don't share those experiences. And we are not that jealous. These risk factors are known as sex-specific risk factors. And they are also known as the sex enhancers. But having said, we also have emerging risk factors, which usually we underplay. But it is interestingly to note that a significant proportion of women are under stress, marital or as a result of otherwise. And you can see that those who basically have abusive partners can be subjected to stressful related outcomes. So having said that, let's look at what we share amongst us. Age we share. And age drives all outcomes of cardiovascular disease. But when it comes to sex, age is a powerful predictor for cardiovascular disease in women. And this slide you may have seen elsewhere, wherein people were saying that, yes, when women are in their fertile stage, they are protected against cardiovascular disease. But it is not shown on this slide, because you can see that even at age 20, 30, 40, there is a high prevalence of cardiovascular disease amongst this age, from peripartum cardiomyopathy and other related causes. But what is quite telling from this slide is that by the time you arrive at 70, there is significant proportion of cardiovascular disease amongst women. The ASCVD risk score looked at the prevalence in terms of coronary heart disease. And this graph clearly shows that with age, there is a significant increase in the prevalence of coronary heart disease, whilst in women, in men, it's plateaued. So when a woman comes in with atypical symptoms, which might be chest pain, please do not just abandon or dismiss that individual. You might be dealing with a coronary event in terms of your assessment. This study was actually carried out by Okello and his colleagues, wherein they looked at the prevalence of hypertension by age. And this is called the 7 SIWA study, wherein 7 communities were selected in West Africa and East Africa. The Nigerian communities were exclusively, West African communities were exclusively selected from Nigeria, whilst the East African communities were selected from Tanzania, Uganda, and Kenya. And having said, if you look at this graph, unlike the previous notion that we have that women are protected during their fertile stage, you can see that the prevalence of hypertension by age and sex, right from 30, is significantly higher as you increase in age. And you can see from this graph that by age 40, there is an increase in the trajectory of this curve with a significant disparity in terms of the prevalence of hypertension. Taking a closer look at this data, when you look at women who were hypertensive, there was a significant proportion of those who were untreated compared to men, as you can see on these yellow bars.
And those who had hypertension already, a significant proportion of them were uncontrolled in comparison with their male counterpart. But what was striking for me in this data was that in comparison with the East African populace between women, you can see that the West African women had their blood pressure being uncontrolled in large numbers. If we can see that in Nigeria, I believe this is what we can see in Ghana as well as where I am coming from. So it's a data which we should actually look at in the sense that we can also extrapolate and try as best as possible to manage our patients. The effect of hypertension on cardiovascular diseases was actually shown in the JNC7 data, which shows that even at high normal blood pressure, you can see that the impact of hypertension on cardiovascular disease is quite telling. And for those who may not be statistically oriented, if you take a cumulative incidence of 6 across male and women, you can actually see that more women were impacted unlike that of men. So hypertension should be taken very close whenever we assess our individuals. This slide again has been shown by previous speakers, but I should just bring to your attention that when you look at the traditional effect of diabetes and smoking, there is disparity, and this confers a greater risk amongst women than men. And if you look at the effect of diabetes on the relative risk of cardiovascular outcome, you can see that heart failure and myocardial infarction is about 2 times that of men. And even across the entire outcome, women were leading, and women were dying more from cardiovascular disease. The issue of smoking has already been informed, wherein less women smoke. But when you look at the effect of smoking amongst women, if you adjust the age based on the incidence ratio, you can see that across all the age group, more women were affected and more women suffered from acute myocardial infarction. And when we evaluated all the data in terms of all age outcomes, more women had myocardial infarction. So let's look now about the effect on sex and the outcome of non-ST segment myocardial infarction. Sharma and her colleague meta-analyzed 10 data from the TIMI trial. For us, cardiology, TIMI is thrombolysis in myocardial infarction. And this data is quite informative. The unadjusted risk related to major adverse cardiovascular effects is similar to that of men and women. But when you look at the all-cause mortality, it was beneficial for men, meaning that women were at a higher risk of dying from non-ST segment elevation. And if you could take a look at this curve, even without a statistician eye, you can see that women, the mortality from women was higher across all the groups. So, what about dyslipidemia? We've been informed that it is a harbinger for atherosclerosis. And we've been informed about the different subsets of dyslipidemia. Looking at the data, one of the largest study from China was published in BMJ Open. And you can see from this data that women, we are significantly affected when it comes to dyslipidemia across all subsets. And we can see that women around 30 to 40, we are significantly affected. What about what's happening in Ghana? The AOGEN study, which was published in PLOS +1, basically was reported by Agongo. And this study was the burden of dyslipidemia and factors associated with lipids amongst adults in northern Ghana. And it was not surprising that dyslipidemia was actually documented. And what is very important in this data was that there was significantly high proportion of triglyceridemia amongst women. And we know from science that triglyceridemia is 3 times more atherogenic for women than that of men. Maybe the Ghanaian Dyslipidemia Association or Society conducted a summit, and I believe most of you must have attended this summit, wherein their statement was that collaborative effort is needed to tackle dyslipidemia in Ghana because there is an upsurge of atherosclerotic cardiovascular disease in Ghana. Some of us like it big because big looks better. I'm not saying all of us, but some. But Ajeman, in his study, reviewed obesity in Africa. And they stated outrightly that obesity is quite alarming, and it is increasing in Africa at a very fast rate. And it is affecting predominantly women, as well as those who are in urban areas. Looking at this data from WHO, even though it's old, Ghana was second to Lesotho when it comes to the prevalence of obesity. Maybe the Ghanaians like it big, but the rest of us don't like it big. On a more serious note, the rising level of obesity in Africa is quite interesting, and it is a burden if action is actually not taken. The effect of obesity in cardiovascular system is shown on this slide. And again, this was mentioned, but in the assessment of cardiovascular risk, you can see that those who were severely obese in comparison to those who were not obese amongst women, women who were severely obese were 3 times more likely to have heart failure, 2 times more likely to have coronary artery disease and stroke in comparison of severe obese and that of normal weight. We can actually see from the data also that was actually brought by Lambert and Nettle from a South African study in terms of inactivity. And I believe a significant proportion of us don't exercise. And when we looked at the poking exercise that I was recently conducted, I heard from colleagues that they don't have the time to exercise. And this data tells us that women were inactive, and this study was carried out in 2000, 2006, and 2012. But what is striking from this data is that the daily adjusted life years amongst women was significantly high. And please, ladies and colleagues, whenever we see our female patients, no matter how big or small they are, let's inform them that they should exercise. Even you, the health practitioner, might not be exercising, but do as I say, but don't do as I do, if I'm right to say that one. Let's look at the unique risk factors. And you can see from this slide that women are affected at all age. And I've decided to preview the presentation by looking at those who are young, looking at the pregnant, and as well as the elderly. Unfortunately, we don't have elderly retired colleagues amongst us. So I'll be spending most of our time talking about the young as well as the pregnant, and maybe that of the elderly. So when we talk about risk evaluation or assessment in the young, these are the spectrum of information that you should get from them. Age of menarche, polycystic ovarian syndrome, which was already mentioned by a colleague yesterday. And if you look at the Norflux study, which was carried out in the UK, trying to see whether there is a correlation between early menarche and cardiovascular disease, it was shocking to note that a cohort of middle-aged women were evaluated, and they were simply asked when did they actually commence their menses. Those who had their menses below age 11, you see that a significant proportion of them already had dyslipidemia, diabetes, and the like. And when there was an adjustment of this data, excluding all other odds parameter, you can see the U shape. And it is telling from this data that if you are a woman who may have had your menses as early as age 10, you have the risk of 28% of developing cardiovascular disease. And if you are a woman who may have been unfortunate to have your menses as late as age 17, you also have the risk of developing cardiovascular disease in comparison to the standard age of 13, which is usually known. If we can go further, I can see from the faces of our colleagues that some of them we are grimacing, and some of them we are actually smiling. Polycystic kidney disease has already been mentioned, but the take-home message of this slide is that polycystic kidney disease, polycystic ovary syndrome, is a heterogeneous syndrome with several subsets. And that which is associated with cardiovascular disease, as was mentioned yesterday by Colin, is the hypergonadotropic type. And it is associated with all these parameters. But the take-home message here is, if you are evaluating a patient, especially a female patient, who has metabolic syndrome, don't just say it is metabolic syndrome. Please call in the endocrinologist so that they can assist you in excluding polycystic ovarian syndrome. Because polycystic ovarian syndrome from meta-analysis shows that there is a twofold increase in the risk of cardiovascular disease. This data is from the Nurses Health study. Looked at menstrual irregularity and flow amongst women. And they realized that those who had very irregular menses, the odds of them having cardiovascular disease as a risk is about 53% in comparison with those who had regular menses. So across all age, everybody seems to be at risk of developing cardiovascular disease. If we can move now to pregnant women, what about parity? From the multi-ethics study on atherosclerosis, clearly shows to us that if you have parity of 5 and more, there is an increased risk for you to develop cardiovascular disease with time. And in another study that was carried out in Sweden, you can see this J curve clearly showing that those who had parity of 5 or more were at an increased risk of 40% in developing cardiovascular disease. And I believe nowadays, even in Africa, women tend to have 1 or 2 or 3, but that doesn't preclude or exclude you not from having cardiovascular disease. You can see from the parity assessment, and they wanted to know exactly what was responsible for the increased prevalence of cardiovascular disease amongst women, amongst those who were multiparous. They looked at their coronary score, and what the coronary score indicated was that those who had more than 4 kids were at an increased risk of developing cardiovascular disease, and there was also a high prevalence of calcium at the coronary score. But the question we should ask ourselves, coronary artery score is an independent risk factor for a prediction of cardiovascular disease. So these data should be taken with a pinch of salt. This has already been mentioned, that 1 in every 10 pregnant women should or would have gestational diabetes. That which I believe a significant proportion of us may not know is that 70% of those who develop gestational diabetes will end up developing type 2 diabetes by age 5 years. So it's your business in the assessment of your patient to ask and follow your patient as long as you can. Because if you leave them, there is a high incidence of the individual having cardiovascular outcome as high as 25% with stroke, angina, and myocardial infarction. This has already been mentioned, and we know that 8% maximum of our pregnant women will develop preeclampsia as a result of hypertension. We know that 4-fold of these who had eclampsia will have heart failure, and 2-fold of them will also develop cardiovascular disease. But what is also seen is that those who tend to have complication related to pregnancy in eclampsia will have a higher prevalence of cardiovascular outcome in maternity. And 2 out of every individual who may have had preeclampsia will die from cardiovascular disease. So the gynecological history and obstetric history is extremely important when we assess our patients from a cardiovascular standpoint of view. When a black woman is pregnant, it's so beautiful to look. But the irony is that evidence had shown that there is a 40% increase in the risk of a black woman having subsequent cardiovascular outcome. And you can see from the bars, from peripartum cardiomyopathy across the board, when compared to whites as well as Hispanic. So it's quite frightening at times when somebody has pregnancy and women tend to have their stress, and that's the beginning of their stress when they are pregnant. And a significant proportion of you seated here can attest to that fact. If we can move on, 3 to 4 of every pregnant related women in a black may have complication amongst 100, and this is extremely important. I may not have time to go through this, but it's like the chicken and egg causality effect. Were these women actually healthy before they become pregnant? Or were there underlying effects like glucose intolerance, obesity, and hypertension? Yes, it could be, but there are mechanisms that have been explained in by previous speakers that can result in the penultimate effect, which is cardiovascular risk. Let's look at premature menopause. And this data is actually from the UK Biobank, showing a linear curve. You can see that women who had premature menopause before 40 had 26% increase in the risk of developing cardiovascular disease, even when all odds were adjusted, including age, sex, including age, smoking, systolic blood pressure, and diabetes. So, if we can go a little bit further, those who had premature in them developing cardiovascular disease. And what is quite interesting, we have surgical menopause and medical menopause. The details I will not go, but the Kappa-Meier shows here that women who had surgical menopause were increased in risk of developing cardiovascular disease even more than those who had premature natural menopause. But in comparison with the standard, women who had natural transition to menopause were at relative risk. Looking at the sex hormones, for men, our sex hormone will depreciate gradually over time. And that's why even at 70, some of us can be functional and we can still make babies. For women, there is a drastic drop during their menopause. There are multifactorial reasons from physiological pathways and behavioral pathways. And you can see that anxiety can result in heart failure, and heart failure and the outcome of cardiovascular disease can result in the other way around. Looking at the women's initiative, 900,000 women were actually evaluated. And during that course, they were followed for a period of 4.1 years. And depression was an independent risk factor amongst them. This slide is quite interesting. And it tells us that women do suffer during their marital home. And it's a Stockholm female coronary score, which shows that amongst women who were married or cohabiting with their male partners and those who have stress that is related to unhappiness, threefold of them will have coronary heart disease compared to those who were living alone, irrespective of whether they were having issues from work. So I'm not saying that girls that are not married should not marry. This is just data. But what this slide is also telling us that men, irrespective of whether they are married, whether they are happy or not, it has no effect on them. So, I think I can use my 5 minutes to go through this because I just decided to add this, which is outside the scope of my presentation. And when you have evaluated your patient, what do you do next? It is interesting to note that you as the clinician should be able to risk stratify your patient. And there are several scores that are now available. We have the Framingham score, which is now outdated. Now we are using what we call the ASCVD score, and the Americans are using it extensively for the registrars, you should note. And we have the WHO ISH risk score, which is familiar to all of us. And in addition to that, we have the score risk system, which is used by the Europeans, and the Q risk, which is used by the Brits. We have other scores that we can use for secondary prevention, TIMI, Cadillac, and Grace risk. These are for us hardcore cardiologists, but this is for primary prevention. The essence of the risk score is not just to calculate figures. It is a process so that you can establish a dialogue and relationship between your patient. And you can see that the ASCVD risk score is an app which has about 9 parameters that you calculate. If you calculate them, it has its own parameters which you can see. It predicts the absolute 10 years outcome of somebody to have cardiovascular disease. And those who have a low score of less than 5, you can tell them to go and be at peace. You have those who are at borderline. Those at high risk, it is imperative for you, the clinician, to start them on statin. It's a class 2B evidence that is well known. And those with borderline or intermediate risk, you sit them down and dialogue as to what next. Now you evaluate their so-called risk-enhancing factors, which was discussed yesterday. And you can now decide whether you can do your coronary artery score. Because the coronary artery score is an independent tool that looks directly into your coronary artery. And in America, I believe in Ghana, some of you guys are practicing this. The evidence of the coronary artery risk score is carried out by a non-contrast computer tomogram. And you look directly at the calcium in the coronary artery. If you see calcium in the coronary artery, with or without evidence of symptoms, you should start the patient on statin as well as aspirin. And the coronary artery risk score basically integrates the risk exposure of genetics, novel as well as traditional factors. And if your coronary is absent, basically it means it is 0. But a 0 score is not suggestive that the individual might not have cardiovascular disease. And this is the evidence, because we are talking about male-female meeting, wherein women can have a worse coronary artery score. These are the last slides, so permit me to go through the WHO ISH prediction score, which is used by almost every sub-region that you think of. West Africa, East Africa, Europe, as well as America. And the WHO prediction score basically tells us about the 10-year risk of fatal and non-fatal major risk of heart attack and stroke. In addition to that, it helps us to identify those who are at high risk and to motivate our patients in terms of behavioral changes and whether we should start them on antihypertensive, statins, or aspirin. These are the basic parameters that you see. And you have 2 charts, one that deals with cholesterol and one that does not deal with cholesterol for those who might be in a setting where they don't have access to lipid values. And what does it state? These are the 2 charts which are familiar with us. This chart is for those who have cholesterol level, and this chart is for those who don't have cholesterol level. So let's go through briefly. We have a female who is diabetic, smoking, 36 years old, with a systolic blood pressure of 160 and a cholesterol of 75%. Where is the risk? So female, you concentrate on the female aspect of the chart. Patient is diabetic, you concentrate on the diabetic aspect of this chart. Patient is 56, you concentrate on the patient does not smoke. So you concentrate on the area where the individual smokes. Patient is age 56. So you concentrate on this area where you can now evaluate your systolic blood pressure as well as your cholesterol. And since this patient has a cholesterol of 7.5 and the patient has a systolic blood pressure of 160, the risk of this patient is 40%. And there is a 40% likelihood that this patient will have cardiovascular disease. It's you, the incumbent responsibility of the clinician, to discuss with your patient that yes, you should start aspirin or you should start cholesterol, as already been indicated from the evidence. What about those who don't have cholesterol? Let's go through the exercise briefly. Again, you look at the female aspect, as you rightly see. The patient is non-diabetic, so you go straight to where the individual is diabetic. The patient basically is 56. So you look at where the age falls, and the patient, he does not smoke. And since it's 56, you look at the area where 56 falls and the blood pressure of 160. And you see that the risk is very high. So going through this, when once you have a patient who has a very high risk, it's your responsibility as the clinician to discuss with the patient the importance of aspirin as well as the importance of statin, because it's extremely important for your patient. The WHO ISH of itself has its own odds. You cannot use it in individuals who have well-established cardiovascular risk factors, those who already have high cholesterol level without effects of cardiovascular disease. All you need to do is put them on cholesterol medication already. And it's also affected by these which you've already seen. For the purpose of time, I'll just brush through. The WHO prediction chart can underestimate certain disease conditions. Patients who are hypertensive and already on medication, okay? Menopausal women. So the question is, what about women who are already in their menopause? It underestimates. And that's why the ACVD score is extremely, extremely important. And you can use them for us in cardiology simultaneously. And these are the other factors that could be responsible. So, having said lifestyle, talk to your patient about lifestyle. If the patient needs aspirin and statin, prescribe, as long as they fit into the level of evidence that is available. Blood pressure should be checked. We looked at the evidence. Cholesterol should be controlled. Cessation of cigarette, diet, diabetes, and exercise are key. So the take-home message: women are unique. And they are unique so much that they were given extra risk factors by our maker. And in so doing, it cut across all their lifespan. And we should look into their history. We should take adequate history from their reproductive assessment. And we should also look at the outcomes of their pregnancy. Take history about whether they have reached menopause, because most times we only ask, when was your last menses? That's what is concerned to us as clinicians. And we should go strictly by the guidelines, and we should use the WHO ISH score as well as the coronary artery score. listen to women. They might be making sense, even though they can be confusing at times. Because women are just more complex than you may think. And that's the reason why maybe at times we dismiss them. Thank you very much to the Ghanaian College, Society of Cardiology. And thank you for saving the woman's heart. Thank you to you all.
Thank you, thank you. Thank you very much, Professor Russell. Let's applaud him again and appreciate him. Thank you. Thank you so much for that. I'm sure that without a shadow of doubt, we all know and have been made aware of the cardiovascular risk assessment in women. And I think we also know that men have a particular and specific cardiovascular impact on women. So, and most important of all, men, listen to your women. So thank you very much, Professor Russell. We women, we are very happy. We will move on swiftly and we will receive an online presentation by Boringa, who is our bronze sponsor. IT, please, are you ready for us? All right.
So good morning, everyone. I hope you can hear me. And see my presentation. Very good. So I won't take much of your time. My name is Dr. David Kamau, and thank you so much, Professor Russell, for that impactful presentation. I will have about 10 to 12 minutes just to build, and it's a pleasure. First of all, thank you to the President of Ghana Cardiology Congress and the Society and the LOC members for inviting us and for the collaboration. So I will talk about optimizing heart failure management across different care settings with evidence from the Emperor Heart Failure Program. Of course, this is one of the cardiovascular disease and an unmet burden. And if you can see my screen, heart failure is one of the cardiovascular disease, as mentioned by the previous faculty, and the burden is increasing as well in sub-Saharan Africa. And this is a global perspective on the same. And I know from a local perspective in central Ghana, there was this retrospective study which looked at the current trend in admissions and some of the risk factors. And I just want to highlight between 2004 and 2015, history of previous heart failure, excessive alcohol use, and hypertension were identified. And we know in our region, the major etiologies, of course, is mainly directed to dilated cardiomyopathy, hypertensive heart disease, as well as here in East Africa. So until recently, as you know, there is an unmet need around HFpEF management, and most of the clinical trials or the evidence have not met most of their primary endpoint, and this is where the SGLT2 inhibitors come into space. From Boehringer Ingelheim, there is a specific dedicated program looking at exploring the impact of empagliflozin on the major clinical cardiovascular and renal outcomes, from the landmark type 2 diabetes trial, from the EMPA-REG trial, to the heart failure studies, and of course, ongoing studies looking at different care settings on the same molecules. And of course, recently, the EMPA kidney study, the broadest of the SGLT2 inhibitor trial that also showed and was stopped early. But today we focus on cardiovascular disease and specifically heart failure. So as you all know, during that ESC 2021, Emperor Preserved was the first SGLT2 inhibitor trial to show positive primary endpoint benefits or outcome. And this was a specific trial dedicated to 2/3 of the patients who had HFpEF, and 1/3 of this patient had what we call now heart failure with mildly reduced ejection fraction, which of course composite HFpEF population. Of course, the trial was empagliflozin 10 mg versus placebo. The aim was to see whether empagliflozin has benefit in terms of reducing the primary endpoint of time to first cardiovascular death and adjudicated hospitalization for heart failure. As you saw in the previous study done by Dr. Lambert et al., hospitalization for heart failure is a common comorbidity, and of course inform the prognosis of heart failure. So I won't dive into this much, but of course, as highlighted, the new heart failure definition has definition across different heart failure spectrum, and with HFrEF, with EMPEROR reduced trial, this was positive. And of course, the EMPEROR preserved after what I've just highlighted is among the first trial within the SGLT2 inhibitors, and of course, the shaping guidelines nowadays or now that there is a molecule that you can, of course, initiate across ejection fraction spectrum in different patient population to prevent or reduce the risk of cardiovascular death and or hospitalization for heart failure. This is the benefit, and you can see the clear definition or the clear benefits seen in EMPEROR reduced or those with HFrEF as early as within the first 12 days. And in EMPEROR preserved, majority of course, these patients were women. And of course, we know there's a lot of heterogeneity among this population as early within the first 3 weeks. And this was consistent across the trial benefit. This is what I just wanted to highlight, that the benefit for your patient when initiated across ejection fraction, whether you had HFrEF or HFpEF, the benefit was seen as early as you can see in this particular calendar days and sustained during the whole trial duration. So this, of course, in the EMPOWER program, we pulled these patients in the HFrEF and HFpEF, and the benefit was seen across various ejection fraction spectrum, meaning this putting empagliflozin as the first heart failure drug to significantly reduce the risk of cardiovascular death and hospital for heart failure across the entire spectrum of ejection fraction. So the question is, and what about outpatient setting in acute heart failure? So of course, as you can see, there's a huge unmet burden. And of course, the repeated hospitalization for heart failure is a major comorbidity to our patients, to the hospital, to the resources that we have. And of course, there's a dedicated trial that looked at prospectively addressing in-hospital initiation of empagliflozin in those patients who were admitted with acute heart failure, regardless of their type 2 diabetes status, and regardless whether this was a de novo or a decompensated chronic presentation. So you can see the timeline there to heart failure, and this are some of the patients that present to our setup. And of course, within the 90 days, the morbidity, the burden, and the mortality risk is increased as much as 10%. So looking at acute heart failure in local setting, in one of the largest teaching hospital in a recent study here, done by most of the faculty members within Ghana, cardiologists. And of course, looking at etiology of acute heart failure in this particular study, majority, as mentioned before, the commonest etiology we know as hypertension. But of course, I just wanted to mention that repeated or history of previous heart failure was among the contributing comorbidities. So this is a very important endpoint, of course, consistently measured along most of the SGLT2 inhibitors trial. And of course, this reflects the burden of the disease, even in an acute heart failure setting. So this is just an overall looking at the repeated, survival rate and increased mortality rate as you progress to repeated and subsequent hospitalization for heart failure. Same thing, initiation of guideline-directed medical therapy is very poor in hospital. And of course, various reasons, including worsening renal failure, poor adherence, and it's paramount to investigate whether a molecule that has been studied outside hospital setting can have benefit within the first 90 days of treatment, just to improve and provide the level of evidence there. So EMPULSE trial, as you can see, was assessed or planned to establish whether those patients who were admitted with acute heart failure, once they were stabilized, they were randomized with a placebo arm in patients who were, of course, on best of standard of care, given empagliflozin 10 mg, and the evidence or the primary endpoint looked at a very big composite of a net clinical benefit, which included cardiovascular death, fast hospitalization for heart failure, how were the patients' quality of life improved after the 90 days. And these patients were randomized within the first 5 days once they were stable, and were the number of secondary endpoint. But the key thing is patients who were type 1 diabetes, who had an eGFR less than 20, were extremely excluded from this trial, and those who required inotropic support or cardiogenic shock. Of course, the normal parameters, the stabilization criteria, the inclusion criteria, of course, fitted patients with acute heart failure, whether de novo or decompensated. all those patients had to be stable. So within the first 3 to 5 days, all those patients didn't have or were not required to be hypotensive. They didn't require increase in IV diuretic use, no inotropic support. And once they were stable, they were randomized and followed up within the first 90 days. What I wanted to highlight to you here is that EMPALS or empagliflozin in this trial showed that those patients who were on empagliflozin arm were 36% more likely to have a net clinical benefit, which included a number of composite endpoints. What I want to highlight here is that death, was a major contributor or a major endpoint there because we don't want our patients to die. But the major driver for this particular 36% benefit seen with empagliflozin was mainly driven by hospital for heart failure, as you can see clearly here. Meaning, and of course, building to the discussion about hospital for heart failure and of course, the morbidity and the prognosis for heart failure patients. So of course, you initiated your patients who are stable, you're worried about the tolerability of empagliflozin initiation in hospital, and you like to follow up them in the next 90 days. All the safety concerns, including the risk of ketoacidosis, was as low compared to the placebo. UTI was even less with empagliflozin arm, and concerns around volume depletion was not as increased compared to the placebo arm. And this completes the whole picture that you can actually initiate empagliflozin in hospital once they're stable with acute heart failure, regardless of their patient's type 2 diabetes status. And the evidence for EMPALS, it just complements the evidence that we have for randomized control trial in the HFrEF population with EMPA reduced and in the EMPA preserved, that you can actually initiate empagliflozin for your stable patients with acute heart failure within the 90 days. And of course, the major driver here, as we know, is reduction in hospitalization for heart failure, including cardiovascular mortality. So just to conclude and to build into the discussion, with EMPA preserved trial, guidelines have shifted, and we do expect ESC guidelines as well to accommodate some of this level of evidence coming from the SGLT2 inhibitors trial. So I just wanted to highlight the key changes, and of course, building into the EMPALS study, is that there is now class 1 recommendation for HFrEF, as we all know, irrespective of presence of type 2 diabetes. And just to mention, the 4 foundational heart failure therapies can be initiated simultaneously at low doses. For HFrEF, of course, you need to profile your patient. And for HFpEF, now with SGLT2 inhibitors, there is evidence that you can actually initiate empagliflozin for these particular patients. And the evidence is growing now. In the ACC guidelines last year, there was a class 2A recommendation for HFmREF, that a third of the patient included in the EMPA preserved, and HFpEF more than 50% in the EMPA preserved trial, evidence generating and of course giving these recommendations. The other thing I just wanted to highlight is that of course HFrEF treatment is limited to those with, so those patients who had a left ventricular ejection fraction less than 40% and improved within serial measurement. Of course, they need to continue on HFrEF treatment. In summary, as we of course engage and look and discuss more about cardiovascular disease, I would just like to mention that there is now clinical benefit seen with empagliflozin, that you can initiate empagliflozin for your heart failure patients, those with HFrEF and those with HFmREF and those with HFpEF. And of course, what I just wanted to complement along the care of our patients, the risk of reduction in terms of possibility for heart failure and cardiovascular mortality has been consistent across the different phenotype. And of course, the benefit is seen as early as within the first 12 days of initiation of empagliflozin, even the first 3 weeks, depending on the phenotype. And now with the EMPALS study, which of course complements the 2 trials within empagliflozin, that you can actually initiate your stable acute heart failure patients, regardless of their type 2 diabetes status, and whether it's just a first incident or a decompensated status, empagliflozin can be initiated within the first 90 days. And of course, the benefit and the take-home message here is that it is safe to initiate empagliflozin. It's quite tolerable. The benefit is there across ejection fraction spectrum. And of course, we look forward to more discussion around heart failure initiation. And of course, thank you so much to all for your attendance. And of course, I will solicit for questions that may arise. And I hope I didn't pass my time. And it's a pleasure. Thank you so much.
Thank you. Thank you very much, Boringa, for that insightful presentation. We will now continue on our journey, and indeed we will turn our attention to indeed a process that is unique to women. We will look at pregnancy and the heart, and it's a great pleasure. So we will turn our attention to pregnancy and the heart, and it is indeed my delight to introduce my friend and my professional colleague, Dr. Mrs. Jan, to give us that presentation. Thank you. We will take her presentation, and after that we'll have our snack break. Thank you.
Thank you very much, Prof. Yao, for the introduction. Okay, good morning, everyone. And so just an outline of my presentation. We will go through the introduction, a brief introduction. Then we will do a summary of the physiological changes that take place during pregnancy. We will mention the WHO classification of maternal cardiovascular risk. Then we will discuss a few of the common medical conditions during pregnancy, and then we will conclude. In terms of introduction, we can say that the prevalence of cardiovascular disease found in women of childbearing age has increased. And this increase has been attributed to increasing number of women at advanced maternal age undergoing pregnancy. You know, now there's an increase in vitro fertilization. So women are getting pregnant at a later age. They're doing their careers first, and then they're going on to making children. We have increased comorbid pre-existing conditions. Because they are older, the chances of hypertension and diabetes in this group of patients is also increasing. And then with the improvement in cardiovascular surgery, we have a growing number of women with congenital heart disease surviving to the childbearing age. Cardiovascular disease is a major cause of pregnancy-related morbidity and mortality. So in the first world countries like America and so, it is the #1 cause of death in pregnant women. We have profound changes occurring in the maternal circulation that tend to have the potential to adversely affect maternal and fetal health, especially in those who have underlying cardiovascular conditions. And because of that, it is very important that all cardiologists and primary care clinicians have a general understanding of the cardiovascular diseases during pregnancy. And in order for us to reduce the cardiovascular diseases and to reduce mortality in women who get pregnant, we need a specialized multidisciplinary team to take care of those patients when they are pregnant. And this team consists of a cardio-obstetric team, which we can sometimes refer to as the pregnancy heart team, to take care of these patients. And it consists of obstetricians, cardiologists, anesthesiologists, pharmacists, nurses. And if possible, we can also have geneticists, because Prof. Yao mentioned all the genetic complications that patients get during, they can pass on to their children. and then, if possible, maternal and fetal medicine doctors. And these team of doctors are supposed to advise these patients even before they get pregnant. So we need to give preconceptional counseling. We need to give them information about the drugs that they are taking for their cardiovascular disease, because some of these drugs are fetotoxic and should be stopped very early during pregnancy. We need to advise them about family planning. We know we're in this part of the world where every woman wants to bear her own child. And many women like plenty children. They believe in having plenty children, I guess maybe because of lack of education. And so you tell the patients, you need to inform them that they need family planning. Some of the patients have to do the family planning without telling the husbands, because some husbands are very stubborn. And they are not the ones carrying the children. They are not the ones with the cardiovascular disease. And so sometimes I have to advise patients that they are the ones who's going to suffer the consequences and not the husband. So our aim really is to please ourselves, take care of ourselves, and not so much the husband. As Dr. Russell showed, the stress, a lot of the stress that the females undergo comes from the men. So pregnancy induces a lot of physiological changes on the cardiovascular system that is there to meet the increasing metabolic demands of both the mother and the fetus. And so these changes can have devastating consequences on patients who have cardiovascular disease. And so in this diagram, I'm showing how I'm just mentioning, as I said, a summary of 4 cardiovascular factors, how they change during the pregnancy. And the blue curve is showing the cardiac output. Our gray is showing how the heart rate changes as pregnancy progresses. The red curve, as you can see, it shows the change in the blood pressure. And the yellow curve is showing the systemic vascular resistance, how it changes as pregnancy progresses. And as you can see, the cardiac output can increase up to about 50% during pregnancy. And that is due to the increased plasma volume, the increased heart rate during pregnancy. We also have a decrease in the blood pressure very early during pregnancy. And slowly the blood pressure rises up to the preconceptional levels. And that is due to the drop in the vascular resistance. Again, as you can see, during delivery and early the postpartum period, there's drastic changes in those cardiovascular factors. And if they are not properly managed in patients who have cardiovascular disease, it can really give to fatal outcomes. So because of the risks that pregnancy poses in patients with cardiovascular disease, we need to classify our patients even before they get pregnant, so that they are aware the risk that pregnancy would pose on them. And there are several scores available to classify these patients. The one that is most validated is the WHO classification. And it classifies the patients into 4 risk groups, with group 1 having very low risk, group 3 having very high risk, and group 4 are those where pregnancy is contraindicated. And so patients, for example, who may have been operated for VSD and ASD will fall in risk category 1. Patients maybe who have VSD, ASD, and they are unoperated, they will fall into the group 2. And patients who have cyanotic heart disease will fall into group 3. And all these, there's a table online, so you see all the cardiovascular disease, they're already in those specific groups. So you don't have to memorize. When you know that the patient has a certain cardiovascular disease, you just look and see which group that patient falls into, and you inform the patient so that she's aware of her cardiovascular risk if she gets pregnant. And because patients in group 4 is so very, very important, we need to know offhand the group of patients where pregnancy is contraindicated. And we see in all patients who have pulmonary hypertension, all patients who have a left ventricular ejection fraction less than 30%, if they have New York Heart Association classification 3 or 4, they should not get pregnant. Patients who have previous peripartum cardiomyopathy and they have a residual impairment in their left ventricular function, it is also contraindicated. Those who have severe left-sided valvular heart disease, those with dilated aorta, and they have Marfan syndrome or bicuspid aortic valve, and those with severe coarctation. They should not get pregnant, or if they get pregnant, you should terminate the pregnancy. The most frequent cardiovascular disease during pregnancy is hypertension. And because of that, the obstetricians are very well versed with the management of this disease. Hardly ever do they need the input of the cardiologist. So the hypertension is classified into 4 groups: preeclampsia, eclampsia, gestational hypertension, chronic hypertension, and chronic hypertension with superimposed preeclampsia. So just in summary, we know the medications to use in this group of patients. Most of them will be on their antihypertensives before they get pregnant. So this may need to be changed when they get pregnant. So the first-line drugs, methyldopa, nifedipine, labetalol. Those who have severe hypertension, they may need IV medications, and so we would use the IV labetalol, hydralazine, and GTN if there's signs of pulmonary edema. The ACE inhibitors and the ARBs are contraindicated, and atenolol should be avoided because it's associated with low fetal weight. Now we'll talk about a few of the medical conditions in pregnancy. We will start off with congenital heart disease. As we said, that this population of patients is increasing because of the surgical improvement. And patients, even with complex lesions, get pregnant. Most of the times, they tolerate the pregnancy well, but it is important to note that it's not only the pathology per se that affects those patients during pregnancy, but their ventricular function, their functional class, and whether they are cyanosed or not. So once these patients come in and they say they are pregnant, we need to do a baseline echo to know at what level of ejection fraction we're starting with. Many of the times, the patients don't tell us that they want to get pregnant. We advise them against pregnancy, and then they come into the clinic and say, "Oh, doctor, I've missed my period. Oh, doctor, I think I'm pregnant." And it is a little bit very difficult to manage. So sometimes we have to take deep breaths, count to 10, and then you go ahead and you talk to the patient and let them know their risk. I always remember the patient who I managed who had pulmonary atresia. It was very difficult because I spoke to her in the clinic about getting pregnant. She defaulted, then she appeared 1 year later and she said she was pregnant. And I told her in this setting it's going to be very difficult. She was club, cyanosed, SpO2 was 85%. I told her it's going to be very difficult. It's better we terminate the pregnancy. The next week, she came to clinic with her husband and her mother. And they told me that if God allowed her to get pregnant, who am I to say that she should terminate the pregnancy? And she asked me, "Doctor, she wants to keep her child. She wants to bear her own child. She has had 3 abortions, and she really wants this one. So she's asking me to please help her to manage the pregnancy." And it was very difficult, a lot of running around. We became very close in the process. And she gave birth to a beautiful daughter. And the child now is like 9 years. Unfortunately, we lost her to COVID last year. It's really sad. So now I'm the mother of the child. So now let's talk about pulmonary hypertension and Eisenmenger syndrome. As we said earlier, patients with pulmonary hypertension should not get pregnant. the mortality is very high in that group of patients. And the greatest risk is around the postpartum, the early postpartum period. As I showed you on the slide on the graphs of the change in the cardiovascular factors during pregnancy, drastic changes take place around the peripartum period. And so most cardiovascular disease have high risk at that area. So patients who have pulmonary hypertension, they usually are on bosentan. It's contraindicated in pregnancy, so we may need to stop that medication. Thromboembolism is high, so they need to be anticoagulated. And in patients with Eisenmenger syndrome, there's an increase in the right to left shunt during pregnancy. Remember, during pregnancy, you have a reduce in the vascular resistance, the systemic vascular resistance, and therefore it promotes a right to left shunt. It decreases pulmonary flow even further, and the cyanosis tends to increase during pregnancy. In our part of the world, valvular heart disease is relatively common during pregnancy. As a cause, these patients develop heart failure during the pregnancy. And the most common cause is rheumatic heart disease. So all patients who have history of a valvular heart disease, they must be evaluated before getting pregnant. Ideally, it would be good to operate and correct those with severe valvular disease before pregnancy. The left-sided stenotic valvular lesions, they are associated with high risk, whereas those with regurgitant lesions, they tend to do relatively well. So symptoms develop in patients who were previously asymptomatic, and we have that happening very often here in Ghana. So they may have had some mitral stenosis even before pregnancy, but they were tolerating fine. But with the changes that pregnancy imposes on them, then suddenly during pregnancy, that's when symptoms start, and that's when they get to know that they even have a valvular heart disease. These patients, a lot of the times, suffer heart failure during the pregnancy. Again, many of our patients with valvular heart disease have their valve replaced with mechanical prosthetic heart valves. And so the management of these patients is very important for us to know. It is associated with an increased risk. We know that the mothers have a high risk of valve thrombosis and valve dysfunction, and therefore they are likely to get strokes. Again, patients get pregnant, they don't tell the doctors, they just stop the medications. By the time they come, they may have had a stroke. And then, because these patients need to be on warfarin, some of them even continue the warfarin while they are pregnant, it is associated with a high cause of teratogenicity for the fetus and hemorrhage. So the teratogenicity is associated with the early use of warfarin. So using warfarin in the early part of pregnancy. And then the hemorrhage, because we know that warfarin crosses the placenta, and so it can cause bleeding in the fetus during delivery. So warfarin can be continued during pregnancy, but it all depends on the dosage that the patient is taking. So embryopathy is related to the dose of warfarin. So if the patient is on a dosage of 5 milligrams or less of warfarin per day, they can continue the warfarin in early pregnancy, that is during the first trimester. But if they're taking more than 5 milligrams of warfarin a day to maintain a therapeutic INR, then the warfarin has to be changed to either unfractionated heparin or low molecular weight heparin in the first trimester, and again at the end of the third trimester. And then cesarean section. So in patients who go into labor while they're on warfarin, for example, if you have a preterm labor, then these patients should not undergo vaginal delivery, but a C-section should be done in order to prevent hemorrhage. Ischemic heart disease, it has already been discussed, so I'll just do a brief summary related to pregnancy. It is rather rare, but it is potentially fatal. And the risk of ischemic heart disease is 3 to 4 times higher in pregnant women compared to their non-pregnant counterparts. The risk factors are the same, traditional risk factors, but beside that, pregnancy is associated with additional risk factors. And so patients who have preeclampsia or eclampsia, thrombophilia, who undergo a lot of transfusions, postpartum infection, cocaine use, multiparity, and postpartum hemorrhage have an increased risk of suffering ischemic heart disease than other patients. And the risk period is highest, as we said, is in the 3rd trimester or the postpartum period. The causes, as was mentioned earlier, most frequent is related to SCAD or patients who have microvascular disease. The management depends on the presentation, whether the patient presents with STEMI or non-STEMI. And of course, we know that the diagnostic, to diagnose it, angiography is indicated. And then once we do angiography, we can know the cause, and then it depends which treatment management that we take. Aspirin is usually well tolerated, and clopidogrel can be used, though it has some effects on pregnancy. Now we look at the cardiomyopathy and heart failure. Again, it has been discussed a little bit, so I'll summarize so that we don't waste too much time. So the diagnosis and the management of cardiomyopathies during pregnancy is challenging because the patient can present both with dilated cardiomyopathy and peripartum cardiomyopathy. We can define peripartum cardiomyopathy as a new onset cardiomyopathy with a systolic dysfunction, the LVEF less than 45%, without reversible cause, and these present near the end of pregnancy or in the postpartum period in a woman without known heart disease. And the prognosis depends on the EF. The lower the EF, the worse the prognosis. There are factors that predispose women to developing peripartum cardiomyopathy. And as you can see, just being black is a risk factor for peripartum cardiomyopathy. Again, in our part of the world, people start having children early. That is a big risk factor. And people also who have pregnancy late is also another risk factor. The cause is not known, so multifactorial. That's why it makes treatment so difficult. And the clinical presentation, most of the times they present with acute heart failure, but they can also present with ventricular arrhythmias or cardiac arrest. And to diagnose the imaging modality, the best one is the echo, because we need to know whether the EF is high, low, very low. And they can have even normal size ventricles. So you measure the left ventricular end diastolic diameter, it may be within the normal range, but the EF is less than 45% around the end of pregnancy or in the postpartum period. You still say that the patient has a peripartum cardiomyopathy. It's very important to note that when the EF has not recovered to greater than 50 to 55%, subsequent pregnancies should be discouraged because of the high probability of recurrence. And so it is recommended that even if the patient improves in ejection fraction after delivery or after they have been treated for some time, you echo them, the EF has normalized to 55%. You should continue them on treatment for at least 6 months before stopping this medication. That way you reduce the chances of recurrence. Another way to reduce the chances of recurrence is being strict on managing the heart rate. So you try always to maintain their heart rate, maybe around the 70s. That reduces the probability of recurrence. But even if the EF improves after the patient, after some time of treatment, you still need to let the patient know that there's a high incidence of recurrence and they shouldn't rush in. And many stories of patients. You know, I had one who had DCM actually, and she delivered. The EF went to about 30% almost around the time of delivery. It was very stressful. It was my son's birthday. I had to leave home, go to maternity so that we helped during this peripartum period. And I advised her, let's do, she didn't want any form of contraceptive. No matter how much I talked, she refused. And then she got pregnant again after about 2 years. And she was so scared, she couldn't come to tell me she was pregnant. And she hid the pregnancy from me. It's crazy. By the time she came in heart failure that was so bad that we lost her. So the patients, I don't know, the desire to have children is very, very, very high. So maybe we need to understand them a little bit more and do a lot of counseling during that period. Now we say that dilated cardiomyopathy, we'll diagnose it in patients who may present very early in pregnancy with a left ventricular ejection fraction less than 45. Because a lot of times patients who may be in their first trimester, you see doctors write peripartum cardiomyopathy. There's no way it can be peripartum cardiomyopathy in the first trimester. That means the patient has a DCM. The two entities are there, they are closely intertwined, and differentiating them can be rather difficult at times. And all patients who have dilated cardiomyopathy need to be carefully counseled about pregnancy. The management is the same as the management of patients with heart failure with reduced ejection fraction, but again, avoiding drugs that have toxic effects. And these agents are listed here, all the ACE inhibitors, ARBs, ANI, MRA, atenolol. They should not be used in this patient. Our treatment is the same to control the volume status. So here we use our diuretics to reduce afterload. Since we can't use ACE inhibitors, ARBs, or ANI, then we may use in these patients hydralazine and isosabide. Rhythm control, heart rate control, here it is safe for us to use digoxin, and then, if necessary, anticoagulation. The ESC guidelines have recommended also the use of bromocriptine in patients with peripartum cardiomyopathy. Sometimes these patients come in with acute heart failure, and the decision that we need to take depends really on their gestational age. And if it is very early in pregnancy and they present with acute heart failure and the fetus is not viable, we may recommend termination because they have started very badly already. If it is at the later stage, viable fetus, then we discuss with parents and then we take a decision. Arrhythmias, the most common arrhythmias are sinus tachycardia and supraventricular and ventricular premature contractions. These are relatively asymptomatic, benign, and does not require treatment. If there's SVT and the patient is hemodynamically stable, then we can use adenosine. If not, if they're not hemodynamically stable, then cardioversion is important. And amiodarone must be avoided during pregnancy. AF, once the patient comes in with AF and it is a new onset AF, we need to rule out structural heart disease. And the management is the same with rhythm and rate control, strict prevention using our CHAD-VASCO, again avoiding the cardiotoxic drugs. And then the last medical condition that I will mention is the venous thromboembolic diseases. And here we're talking about PE and DVT. We know that pregnancy is a hypercoagulability state, and these patients therefore are at increased risk, particularly in the third trimester and the early postpartum period. We also will have risk factors in those who have undergone C-section or those who had in vitro fertilization. We need a high risk of suspicion in those who present with symptoms and signs suggestive of PE and DVT. It's important to note here that D-dimer testing that we use in non-pregnant patients to rule out PE should not be used in pregnant patients. D-dimer can be normal and can be low in pregnant patients who have PE or DVT. And so we need Doppler, we need imaging when to diagnose this pathology. Our treatment, so the medication, the preferred drug or the preferred anticoagulant is the low molecular weight heparins. The unfractionated heparin has its indication and thrombolysis when required. The NOACs, like rivaroxaban, is contraindicated during pregnancy. And again, because it's anticoagulation and we don't want these patients to go into labor while on the anticoagulant, we need to plan their delivery. And so, because pregnancy is up to 40 weeks, we may decide to deliver them around the 38th to the 39th week. We plan the pregnancy so that we can change the medications accordingly to avoid bleeding during pregnancy and during delivery, sorry. So in conclusion, we can say that cardiovascular disease is a major cause of pregnancy-related morbidity and mortality. Preconception counseling by the multidisciplinary cardio-obstetric team is essential for women with pre-existent cardiac conditions or history of preeclampsia. The left-sided valvular stenotic diseases is associated with higher risk. Peripartum cardiomyopathy is relatively common in our environment as a cause of heart failure with a high potential of recurrence. The ACE, ARBs, ANI, MRAs, atenolol, NOACs, and amiodarone, they are all contraindicated during pregnancy. A high index of suspicion is important in patients with signs and symptoms suggestive of VTE. And D-dimer testing to rule out PE is extremely controversial during pregnancy. Thank you very much for your attention.
Thank you very much, Dr. Jan. That's very insightful. Thank you for the lessons. And I think since it's always challenging to know when a woman will fall pregnant or become pregnant, the preconception counseling is really important. Thank you, Dr. Jan. Another appreciation of her, please. We will now take a 10-minute presentation, online presentation by Bea, who is our bronze sponsor. Is it online? No, it's in person. I'm sorry, in person. He's actually here. You're welcome. Let's appreciate him.
So just so we know, right after this, there will be a short coffee break, and then we reconvene to deal with the questions and answers. So please jot down your questions. 5-10 minute coffee break right after this. Thank you.
Okay, thank you very much. My name is Kwadwo Deajiman from Bea. When you mention Bea, I'm sure most of you are aware that you have been with the Ghana Society of Cardiology from the very first day. The reason is simple. We appreciate what you are doing in saving lives. Dr. Mrs. Jan just mentioned venous thromboembolism before the end of her presentation. And when it comes to venous thromboembolism, we at Bea, we are acutely aware of how important it is, because we know the fatality associated with venous thromboembolism. In fact, I think last year, during one of the presentations by Dr. Duwache, I learned for the first time that because of the fatality associated with venous thromboembolism, some of the guidelines actually recommend that once you suspect your patient may have a VTE, you should go ahead and initiate the patient on anticoagulant therapy even before you send the patient to go for the lab. And that tells us how important and VTE is to us. So we at Bea, we had to come in because we believe in science for a better life. We came in to see how best we could help. And that led to us going to the lab and coming up with a product called Xarelto, which I know most of you are very much aware of. So why is Xarelto quickly becoming the standard of care all over the world? That's at about 2 years ago, we have over 63 million patients who are on Xarelto. It's quickly replacing the standard of care who used to be the enoxaparin and your VKA. It's simply because, like I said, because of the fatality associated with VTEs, there's a need for prompt, effective treatment, and that is exactly what Xarelto delivers. So when it comes to Xarelto in the treatment for VTE, that's your deep vein thrombosis and pulmonary embolism, Xarelto, not only is it effective, but again, it acts as fast as the use of even enoxaparin. So as long as your patient can swallow, the recommendation is that you can start your patient on Xarelto straight away. Again, it's important to remind ourselves of the efficacy of Xarelto. The question is, are there evidence to support Xarelto? Well, like a professor once told me, he said, Kojo, when it comes to medicine, it's an art and a science. The science is what you do in the clinical trial settings. The art is what we experience every day in our lives, how our patients react to the products that we give them. So yes, since I am not a clinician, I can only stick to the clinical trials. But when it comes to the Einstein DVT and the Einstein PE trial, this is a very popular trial. So I'm sure a lot of you have been very much aware of it than I am. You know more about the trial than I do. Especially when you have Professor Azekowusu Nko in the room. You have to be careful what you say. Hi, Prof. Okay, so I'm not going to belabor the nitty-gritties of Einstein DVT and Einstein PE trial, but it's important to remind ourselves of the conclusions that came from these trials. And the conclusions were clear, that when your patients come with DVT and PE, they have venous thromboembolism, and you put them on Xarelto, 15 milligrams for 21 days. And then from day 22, after about 3 to 6 months, you put them on 20 milligrams daily. You are sure that not only is it safe, but you are going to get the efficacy that you are looking for. So what about the Einstein PE trial? Again, the conclusions were very clear, that once your patient presents with PE and they can swallow, it's important that you put them on Xarelto, 15 milligram BD for the first 21 days. This is another question we get a lot. That is it a 15 milligram BD for 30 days or 15 milligram BD for how long? It's 15 milligram BD for the first 21 days. Then from day 22, after about 3 months or 6 months when you do your Doppler and check, it's supposed to be 20 milligram daily. And then for some patients, they still have to be on Xarelto for a longer period. The recommendation is that depending on the risk factor, you may continue the patient on 20 milligram daily or 10 milligram daily. Again, in the midst of cardiologists, you can't end without talking about non-valvular atrial fibrillation, anticoagulant in non-valvular atrial fibrillation. And again, one of the largest trials that has been done is the Rocket AF study. And I'm sure most of you are aware. So again, I'm not going to belabor the points for the sake of time, but it's important to remind ourselves of some of the conclusions from the Rocket AF study. The conclusion was very clear. This pooled over about 14,000 patients across the world, including Africa. There's about 240 or so from South Africa. And the conclusion was clear, that the use of Xarelto, 20 milligrams Xarelto daily in your patients who come with non-valvular atrial fibrillation is as effective as putting your patients on the standard of care. And then the safety profiles were similar. But then I said I'm not going to the nitty-gritties of the Rocket AF study, but sometimes the devil is in the details. The question is, what about your patients who are elderly? And then it's important to remind ourselves that in the Rocket AF study, there were over 6,000 patients who were over 75 years. So if you are wondering the efficacy and the safety of Xarelto in patients who are a bit elderly, the conclusions were clear, that Xarelto is effective in both the young and then the elderly. So what of your patients who have come out other comorbid conditions like diabetes mellitus? Again, there were over 5,000 of those people in the trial who had DM. And the conclusion again was very, very clear. Xarelto is very effective in your patients in the prevention of stroke in patients with non-valvular atrial fibrillation with or without a DM. What if your patient have had a prior stroke? They've had a stroke before. Again, there were about 52% of the patients who were in the trial who had previous stroke. who were part of the trial. And again, the conclusion was clear that we are looking at the primary and secondary prevention of stroke in your patient with atrial fibrillation. Xarelto is a drug of choice. What about your patients with renal impairment? Do they have a risk of higher bleeding? And the answer is no. Of course, unless the creatinine clearance is like less than 50 ml per minute. But as long as it's moderate to severe renal impairment, if you're talking about a creatinine clearance of between 15 and 30 ml per minute, it shows that the Xarelto in those patients have fewer major bleeding events compared to those who are on VKA. What if your patients have active cancer? Should you be afraid that your patient may bleed more if you put them on Xarelto? And the answer is no. And again, that was for the clinical trials. And then before I come to the conclusion, like I said, the question we get a lot from clinicians is the dosage of Xarelto. So it's also important to remind ourselves again that when your patients come with DVT or PE, the recommended dosage is 50 milligram BD for 21 days. Then from day 22 out to about 3 months or 6 months, the recommended dosage is 20 milligram daily. And if you need to extend the treatment or prevention of recurrence, depending on the risk factors, you may continue with 20 milligram daily or 50 milligram daily. That is. And then for those who come with non-valvular atrial fibrillation, the recommended dosage is 20 milligram daily. Okay, I've talked about VTE, I've talked about AFib. The question is, are those the only indications for Xarelto? And the answer is no. Yesterday, one of the presenters talked about coronary artery disease, and we at Bayer, luckily for us, we have a dosage to help reduce the limb events in your patient with coronary artery disease. So when it comes to coronary artery disease, the recommended dosage for Xarelto is 2.5 milligram BD plus a low-dose aspirin. Thankfully, we have a low-dose aspirin, that's the aspirin cardio, which you can easily give to your patients on a daily basis. So again, as a reminder, why is Xarelto increasingly becoming the standard of care for patients with VTE and for patients with AFib? It's simply because Xarelto is very easy to start, very simple to maintain, very easy to teach how to give, and very, very easy to take by the patient. So this is how Xarelto comes. They come in the presentation of 50 milligram, 20 milligram, and 10 milligram. I know that when it comes to Xarelto, one of the key questions again we get is the question of affordability. And that's a discussion I've had with some of you since yesterday. The good thing is that just yesterday, I had an interesting conversation with Dr. Duwache, and then he was sharing his experience with me. I hope he doesn't mind me sharing it. How come a number of his patients are able to move on? Yes, I can't pay consultation fee, but it's okay. Yes. So I was asking, okay, he said, look, yes, affordability is an issue. In Ghana, things are expensive. I mean, we have to be clear about that. But the question is this. When you diagnose your patient with a VTE, you are putting a life on the value of that patient. Because unlike other conditions, for instance, it's not a malaria, this is not like some other sexually transmitted diseases. Some of the patients may have between 48 hours and 72 hours to die. So the question is, how much value do we put on the life of these patients? So he said, okay, for him, what he does is simple. You are very busy people, but it takes just a few minutes, sometimes it could be 30 seconds or 1 minute, to explain to the patient the need or the consequences of not sticking to the Xarelto dose. Because it's going to take it for about 3 months to 6 months. And believe you me, some of these same patients who come to our consulting rooms and convince us that they cannot buy, they leave our consulting rooms, they'll go to the next herbal doctor somewhere, and you'll be amazed how much money they spend there. All because they get a reason. So, my plea with you today is that, ladies and gentlemen, can we all adopt the 30-second rule? As you have the patient in front of you, as you realize you have to give your patient Xarelto, could you spend extra 30 seconds of your time in the consulting room and explain to the patient that he has to come out with that 800 cedis or 1,000 cedis a month, or he may end up with a stroke? And you'll be amazed. When they hear that, they will call their children,
They will call their brothers, they will call everybody, and then be able to afford it. Because they are going to take it about 3 to 6 months. Other than that, the beautiful thing is that they will still get the money, but they will not spend it on Xarelto because they are not feeling any pain. And then their lives are going to be in trouble. I want to see my grandfather alive. I want to play with him a little more longer. So if he tells me that he's going to get stroke, definitely most of us will contribute and help them to avoid their Xarelto. Thank you very much.
Thank you very much, Bea. So Xarelto it is. We will now go for a coffee break. Is that right, Doctor? Yes. And be at liberty to bring your snack back into the room. Online questions, please continue. Jot your questions down. And how many minutes? The coffee break? 10 minutes, please. So it is 11:32. So 11:45. We'll convene back in here. Thank you very much.
Once daily Forxiga, dapagliflozin, for patients with CKD with or without type 2 diabetes. In patients with CKD, increased pressure inside the glomerulus can lead to a decline in kidney function. Forxiga slows kidney function decline by reducing intraglomerular pressure. Forxiga helps to lower pressure by reducing blood flow into the glomerulus. This renal benefit is not dependent on the blood glucose lowering effect of Forxiga and is not limited to patients with diabetes. The Forxiga mechanism of action is complementary to that of ACE inhibitors and ARBs, which increase blood flow out of the glomerulus. Treating with Forxiga can help slow the composite of declining kidney function, end-stage kidney disease, and renal or CV death in comparison to placebo. In addition, Forxiga reduced the risk of death from any cause versus placebo.
This is for scientists and those who believe in the potential of science. It starts with curiosity, a surprise in the pattern, an obstacle that can't be explained. Step by step by step, they challenge, explore, and unlock the unknown, fueled by imagination, alone and with others, repeating an experiment 1,000 times to have the chance to get it right. Once, but for forever. Making brave choices, choosing to push the boundaries, and choosing again and again to be led by science in everyday decisions, everyday interactions, no matter where they are. Because putting science at the center of everything is the best way to understand and transform disease, the best way to change people's lives. This is why we believe in what science can do.
Once daily Forxiga, dapagliflozin, for patients with CKD with or without type 2 diabetes. In patients with CKD, increased pressure inside the glomerulus can lead to a decline in kidney function. Forxiga slows kidney function decline by reducing intraglomerular pressure. Forxiga helps to lower pressure by reducing blood flow into the glomerulus. This renal benefit is not dependent on the blood glucose lowering effect of Forxiga and is not limited to patients with diabetes. The Forxiga mechanism of action is complementary to that of ACE inhibitors and ARBs, which increase blood flow out of the glomerulus. Treating with Forxiga can help slow the composite of declining kidney function, end-stage kidney disease, and renal or CV death in comparison to placebo. In addition, Forxiga reduced the risk of death from any cause versus placebo.
This is for scientists and those who believe in the potential of science. It starts with curiosity, a surprise in the pattern, an obstacle that can't be explained. Step by step by step, they challenge, explore, and unlock the unknown, fueled by imagination, alone and with others, repeating an experiment 1,000 times to have the chance to get it right. Once, but for forever. Making brave choices, choosing to push the boundaries, and choosing again and again to be led by science. In everyday decisions, everyday interactions, no matter where they are. Because putting science at the center of everything is the best way to understand and transform disease. The best way to change people's lives. This is why we believe in what science can do.
our seats. And please, for those of you who don't know, there are some, should I say, society paraphernalia at the back, particularly the T-shirts, going for a very affordable price, 50 per T-shirt. So please, let's patronize. Shall we please assume and resume our seats, please?
Hello.
Please, shall we resume our seats? Please, Ms. Parry. Hello. Shall we please set off for the Q&A section? Our chairperson is ready. And therefore, if you have any questions, please note them down. This is the time to ask all those questions. And it goes to our online participants as well. If you have any questions, please drop them in the chat box. Drop them in the chat box, and our resource persons are ready and will be more than willing to address them. Thank you. Please, all resource persons, presenters, assume your seats at the high table. Thank you very much. Please have the questions come in thick and fast. Yes, the Bayer rep is also wanted. Bayer rep. Yeah. So some of the questions may border on the cost of Xarelto. So far, no. No. So I think our panelists are ready. I'll hand over to Prof. Yao to take it away. Thank you very much.
Thank you. Thank you, everybody. Thank you for coming back from the coffee break. Those who are still coming, please come and join us. Online participants, welcome back. And just before we start, before we start asking the questions, we truly want to appreciate our resource persons for the morning, from Boringa, from Bayer, Dr. Jan and Prof. Russell. And please just help me to appreciate them again with a round of applause. Thank you. Thank you so much for your time. So we'll take any questions, please, in person, online. Please ask all your questions. Cardiovascular risk assessment in females, pregnancy and the heart, Xarelto, and from Boringer's presentation as well.
Okay. So we'll take a round of questions.
Yes, please.
Thank you very much. My question goes to Prof. Russell. In your presentation, you were saying that women die more from NSTEMI than STEMI. Is there any peculiar reason why that happens rather than the expected in women?
Thank you. So we'll take a few questions and then.
Thank you.
Please, my question is to Prof. Russell. Prof, sometimes we do see patients who come to the consulting rooms with no comorbidity, no diabetes, no hypertension, no obesity. And they just come because they went to do a fasting lipid profile. And when they bring it to the doctor, you realize the values are really, really high and significant. But these are patients who do not have any underlying comorbidity. Apart from the lifestyle modification, when do you decide to put them on statins? Is there a particular value above the triglycerides, the LDL, that you consider before you put them on statins? Or do you have to do the risk stratification as you mentioned before you determine their risk? Thank you.
Thank you. We'll take two more and then we'll commence the answers.
Thank you. My question goes to Prof. Russell. I want to know how the marital stress was assessed.
One last question, and then we will. Nothing online. Are there any online questions?
Not yet, the last time I checked. No.
Okay. There's one more question.
Hi, this question is for Zerato or Bear. I was just wondering, do you have in this part of the world indigent services or samples that you give out or anything like that here that they do in the U.S.?
Thank you.
Okay, thank you. So we'll give the mic to Prof. Russell.
Yeah, thank you very much for the excellent questions you've asked. I'll do the reverse order in terms of answering to the question. In terms of how the stress was assessed in these paper that I presented, I would like you to read the Stockholm stress study, because there is a list of parameters which honestly I cannot go through because I'm not a psychologist or psychiatrist. But that paper you can definitely have, and it will tell you the parameters, I have to be honest. Because there are times when you are doing presentation, you go predominantly for the abstract and see exactly how it correlates with your presentation. But I will urge you, you can even check it on Google now and see how best you can extrapolate from it. The second question is a valid question. In fact, when you look at the American cardiology guidelines as well as HA, an elevated lipid is a class 2B indication for you to commence statin, irrespective of your risk, be it evaluated from that of the ASCVD score. As I did mention to you, the essence of the risk stratification is not just to calculate values, but to see how best you can stratify your patient based on the guidelines that is given. So if you have somebody in whom you highly suspect, or somebody in whom the risk score is on the low side, but you take other enhancing factors, which of course due to the limitation of time
of my presentation, I couldn't go through all those enhancing factors, but they were already mentioned in previous presentation in terms of the connective tissue disease, rheumatic arthritis, you name them. You can use what we call an interface interaction with that of your patient. Now, when you go to the WHO ISH risk score, it clearly states that there are specific individuals in whom you don't even need to check the risk score. And in the second bullet, an individual who does not have cardiovascular disease but with an elevated lipid. And if you could recall from the studies or presentation which were done, in fact, your cholesterol LDH ratio should be looked at because the outcome in terms of cardiovascular disease is extremely high. Individuals with low high density lipoprotein. For women, for every 1 millimole increase in your HDL, it reduces your risk related to cardiovascular disease by about 10%. So you can rescore your patient, but high LDL, because the objective is primary prevention. So I hope I'm able to ask your question. I may not want to go into all the details, but high lipid in someone, irrespective of whether there are comorbidity or sign, is a class 2B indication for commencement of statin, irrespective of the age, because you're trying to prevent the outcome of cardiovascular disease. The question number one, maybe I guess the way it was presented was not actually understood by you. I take myself as a woman now in your clinic and I cannot communicate that well. And in so doing, I can repeat my sentence once again. When smoking as a traditional risk was looked at, they realized that even though smoking was very low amongst women, when they adjusted age and standardized it according to the incidence of rate risk, in comparison with men, there were more so-called myocardial infarction across all age group. Even when you look at the composite endpoint, which was total age, MI was higher in that study. That study did not talk about mortality because the study was published in JACC, okay? Then the other study which I mentioned was published by Sharma, and is a well-renowned cardiologist, okay? They meta-analyzed 10 studies from TIMI trial. And TIMI, we know, is thrombolysis in myocardial infarction. And they did comparative evaluation between men and women. So the question is, what was the outcome of sex in individual with non-STEMI? And the forest plot clearly show, if you look at that forest plot, the confidence interval actually crossed the line 0. So if you look at the adjusted outcome, okay, the adjusted risk for major cardiovascular adverse event, they were actually similar in the two groups. But what was striking in that data was that there were benefits in the male arm. And if you interpret it in the other way around, we had a higher mortality in the female arm. And if you look at the Kapamaya study, right from the beginning, there was a higher mortality amongst female in comparison with male. So your question is, it's not about non-STEMI or STEMI. It was STEMI in individuals who were male versus female. I hope I'm able to answer your question.
Yes, thank you. If I got your question, you were asking whether we give samples of Xarelto. Please, was that a question?
Who may not be, but need the medicine, but cannot afford it.
Yes.
Are there any charitable, whatever you call it here, I don't know, but US they call it indigent services, like, you know, they can afford it, so you make considerations for those patients. You either reduce the cost or give it to them free.
Okay, thank you. With regards to samples, the answer is no. We could in extreme cases, but with the compliance and the processes it have to go through, you are as good as not being able to give, because it may take so long before we are able to, because I need to come to you for a prescription for a particular patient. It has to go through all the processes to head office, approval from Germany. It's a long process. So though we could give, it's hardly done. On the issue of those who cannot afford, the good thing is that now we have partnered with Muti, M-Pharma. What M-Pharma is doing, that there is innovative service they are providing. When the patient cannot afford, you link them to Muti. What Muti does is that Muti gives them the product at a much subsidized rate, and then give them the option of paying in installment through mobile money. So they spread it for them. For instance, if it's 800 cedis a month, they could give to them at around 500 cedis a month, and then give them the option of every week or every 2 days, they pay something little. So that is what is available. Unfortunately, Muti is not advertising very much as it's supposed to be. But for a number of patients who were referred to me, I directed them to Muti, and it's really helped them. At the time when Xarelto was selling for about, I think 560 then, Muti was selling around 390, and still giving them the option of paying in installments. So yes, that option is there with M-Pharma's Muti.
Thank you. Thank you very much. We'll take our next round of questions, if there are any. So questions on cardiovascular risk assessments in females, pregnancy, and the heart.
Okay, so one more question for Bayer. I wanted to find out, you showed the samples you have done, and you do 20, 15, and 10. I wanted to ask, what's happening to the 2.5 milligram? Is it being taken off the market, or I don't know, or you score the 10 and then we divide it into 4 and give to our patients?
Thank you. Any more questions, please?
Good. Thank you very much. Thank you, Dr. Jan, for your presentation. Very insightful. In Confanoch, something has been started, but it's one side when it comes to cardiovascular disease in pregnancy or in women. So we have what they call the fetal-maternal clinic, where usually there's actually a team that takes care of medical conditions in pregnancy. And in fact, their residents even come to internal medicine, cardiology to do some rotations, trying to learn about point of care, echo, etc. But one of the problems I find when it comes to medical conditions in pregnancy, i.e. pregnancy-induced hypertension and also gestational diabetes, especially when it's pure gestational, is that the obstetricians and gynecologists, usually they will see the patients as long as the patient is pregnant. And then when the patient has delivered, then it becomes an issue. usually they lose them. I wouldn't say to follow up because they don't follow them up. That has been one of our challenges. So they will come back later and then you realize that, oh, when they were pregnant, they had A or B, but after delivery, they were told that they are okay. So I think that's a big challenge. I want to know whether that's your experience too, and what do you think can be done when it comes to such cases? What more can we do to be able to catch these people before they come with complications? Thank you.
So we'll take one more question, then we'll get the answers.
Okay, I wanted to ask Baya, but Dr. Conte, you can ask.
Yes, mine will be a comment on Dr. Prof. Russell's presentation. The data you've presented about the hypertension study across East and West Africa, I found it very, very striking because it shows that regardless of the age, hypertension was more prevalent among female compared to male, okay? And that if you pick up any internal medicine textbook right now and look for risk factors for hypertension, you'll see male sex. So is that changing? And we'll definitely see where the data leads us to as the data continue to evolve. Or probably have we been over-exaggerating the protective effect of estrogen in women with regards to cardiovascular disease? The other thing that I found worrying was the fact that when they look at the control of hypertension, it was poor in women, and particularly worse among the West African women. That also is very worrying because when you look at public health data across the sub-region, it clearly states that women have better health-seeking behavior compared to men. So if that is the case, then the indictment is squarely on us, the healthcare providers. It means that the women are coming to the health facility, but we are either not listening to them. If we do listening, we are not understanding them properly. We are not properly evaluating them, and ultimately not managing their cardiovascular conditions better. And from all the presentation we've been hearing from yesterday to today, emphasizing the increasing prevalence of cardiovascular disease and worse outcome among women, I think moving forward, us as cardiovascular physicians, when it comes to evaluating and managing female with cardiovascular disease, we have to go beyond 50-50. We need to pay special attention to women. And as Professor said, they were created special. It's time we start treating them special. Thank you.
Thank you, Dr. Kante. We are special.
We've been treating them
So please, we'll take, I think Prof. Russell wanted to ask Bea a question.
May I? Okay.
I think the seniors want to comment.
Okay, all right. So
I'm just make a follow-up question or comment. The Prof also wants to make the same comment.
Yes.
I think when you conduct a research in Sub-Saharan Africa, the health-seeking behavior of men and women are different. You know, we did some work in Accra, in Greater Accra. Only 30% of the people who visited the hospital were men. So if you conduct a research within the health space in Ghana, you would assume that yes, the women have more, hypertension than men. That's one. Even when you enter the community to conduct research or conduct a screening, the men will not show up. So it creates a lot of it distorts the actual burden within. The men will go to the hospital only when they are sick, and they even don't go alone. After the wife, force them to go to the hospital. So this creates a certain, image as if the men don't have the risk factors. So I think Prof also wants to ask.
Yes, I think it's the same thing. You talked about hospital space. We also did the community-based, study across the country, and the participants, about 30% were men, 70% were women. And so if you just want to base these facts on research, sometimes you may not get to the real facts. And, for community-based studies, some of the reasons, assigned to this is that most of the time the women are childbearing, women, and they stay at home. The men go to work and that kind of, so they are not readily available. And therefore, when we are interpreting these, data, we have to take this into consideration. For hospitals, for women, any small problem, they will come. Men, has to be critical before they come. So let's take all this. I don't think that that might be the, true reflection of what is happening. Thank you.
Thank you. Thank you very much. Thank you so much. So I'll let Prof. Russell
just
ask his question.
Yeah, Bayer.
And then, yes.
In your presentation with regards to rivaroxaban, we know for sure that most of the drugs, one has to be extremely careful in terms of creatinine clearance. And for some of the drugs, there is a cutoff and limitation. Regarding rivaroxaban or Xarelto, what's the cutoff? Usually some of them is at less than 30 mils per hour. You should not give the drugs. You should go to the low molecular weight heparin, because this is key. And you know that most of these drugs are, the drugs are excreted by the kidney. The second question in your slide, you mentioned about rivaroxaban and warfarin in valvular heart. Non-valvular heart, okay, atrial fibrillation. Because I was concerned that the recent Invictus study that was published shows no benefit in the use of rivaroxaban against that of warfarin. Because the composite outcome in that study was that there were more deaths in the rivaroxaban arm rather than that of warfarin. So it has already changed the Invictus. The Invictus was recently published for the management of rheumatic valve disease, because there were issues whether we should give drugs or not. But again, several comments were brought from the cardiology forum, which we were already discussing. Whether indeed rivaroxaban, if that study is conducted, if you give dual dosing, should be, I repeat, can have an effect more than that of warfarin. So you read Invictus, which is a landmark trial, and majority of the participants in that trial were recruited from Africa and Southern America. Okay, thank you. Over to you. So your comments on that, sir.
Thank you very much. So we'll start with Bea. So you answered. There was another question prior to that. And then Mrs. Jan will answer, and then we'll come back to Prof. Russell.
Yes, thank you very much, Prof. Russell. And then there's another question on whether we have the 2.5 milligram available on the market. And the answer is yes. Unfortunately, we couldn't capture it on that particular slide. But yes, we do have the 2.5 milligram very much available. Kumasi, Accra, anywhere in Ghana, you can have the 2.5 milligram. And then back to Prof. Russell's question on the creatinine clearance. I think in one of the slides that I shared, where we were talking about the renal impairment, the recommendation is that if the creatinine clearance is less than 15 ml per minute, then Xarelto is not recommended. Not just Xarelto, but the other NOACs as well. But between 30 and 15 ml per minute, the recommendation is that yes, you can give, but with caution. And for those patients, the recommendation is that for AFib, instead of 20 milligram daily, it's recommended that you give them 15 milligram daily. But of course, in the clinical setting, you need to assess the risk-benefit ratio, and then you make that decision. So for below 15 ml, for 15 and below, the recommendation is that you don't give at all. With regards to the Invictus studies, I don't have much information on it. So I'll crave your indulgence to go back, check on it, and if you don't mind, get back to you on it, if it's okay.
I know about the study, and that's the reason why I brought it forward. So, but since you are a pioneer for Xarelto, you should be okay with the Invictus studies.
Thank you.
Thank you. Sorry, Prof. You see, one good thing I like about programs like this is that, though it's very intimidating, because you are meeting people like Prof. Russell, but it's also an opportunity to learn. So I'm happy Dr. Kokro is here. Dr. Kokro, I saw you raise your hand. I don't know whether it's related to this or not, but I'm always ready to learn.
Well, I think from day one, there've not been indication of rivaroxaban for valvular atrial fibrillation. That is, in patients who have atrial fibrillation that is caused by valvular disease. So if you look at the Invictus study, it's more on valvular. So you are actually saying the same thing. Just that the Invictus came to reinforce, because there have always been the argument as to whether you could give it or not. And some clinicians had actually been giving it to patients with rheumatic heart disease, etc. So this is coming to clear the air that, at least for now, that when you are considering the NOACs or rivaroxaban for valvular heart disease, atrial fibrillation, valvular atrial fibrillation, it is not indicated. Thank you.
Thank you. Thank you very much. We are running short on time, so if there are any further questions, please make them brief. We'll just take the answers and one more round of questions. So Mrs. Jan will answer now.
Thank you very much. So at Kolibutu, we also have those fatal medical team, and they do manage not only the cardiovascular disease, as you said, related to pregnancy, but the other medical diseases. And it's the same in Accra. It's the same. They only refer the patients that have cardiovascular disease, the disease that they're not very conversant with. But because they believe when it comes to hypertension, they're on top of it. They manage, just as you said, and then after that, they leave the patient on their own. And so maybe what we need to do is communicate a bit more with them and let them know that they need to refer these patients for us, because these are diseases that the patient's going to continue with, and they need proper follow-up. So it's just communication, I think.
Thank you, Dr. Jan. So we'll let Prof. Russell take his answers, and he had a comment. And
with regards to the comment being raised, I think all those who made their comments were absolutely in place. I'm just buttressing. You see, the problem we have in Africa in terms of observational studies is that even for some of the studies we've done in West Africa, in my own place, we see predominantly women. And again, it can be very difficult for you to extrapolate that data to another region. But the question I always ask is, in Africa in general, we seem not to have data that encompasses all in terms of East Africa, West Africa, and Southern Africa. There are so many registries that are now coming, and Pascal has been creating that platform wherein we have involvement of all aspects of West Africa. Collaboration is also extremely, extremely important. But in most of the studies that we do, it's purely preventional cardiology, and it's done in a very small community with a very small sample size, and it will be difficult for you to generalize that data to the rest of the country. And unfortunately, in as much as, yes, some of these studies are being done, look at the STEP survey. Sierra Leone, we did STEP survey 2009. The data were not even published. It was just step 1. Ghana has done step 1 and step 2, and yet still the data that is at hand is something which you cannot extrapolate to another country. So your points are extremely valid, but the take-home message that I need to pass on in terms of my presentation: assess your patient, risk stratify them, and the risk stratification can even give you an insight to the patient.
Because if you tell the patient that your 10-year risk of having stroke or heart attack is 40%, believe you me, they will take it very serious. Rather than just leaving the patient, I want to start you on statin with no evidence. They will say, we are having cramps from statin. But if you tell them that there is a likelihood of 40% or more for you to have this outcome, they will go by that which you've already mentioned. Thanks.
Thank you. Thank you very much. So we'll take 2 more questions. Our time is fast spent and there's another meeting starting very soon. So if there are any burning questions, 2 more. There's one there.
Thank you very much. My question is for Dr. Jan. You talked about rate control in cardiovascular issues, especially the dilated cardiomyopathy in pregnancy. You mentioned that we can use digoxin. You also mentioned atenolol is contraindicated, but I didn't hear anything about the other beta blockers. Bisoprolol, carvedilol, is there any role? Is there a contraindication? Okay, thank you.
One more question. Yeah. Anything online? Do we have any online questions, please? None. There's one more question. Yeah.
Yes. I performed an echo on a lady, and it turned out to, it looked like a rheumatic valvular heart disease, and it was a peripartum. The diagnosis was a peripartum cardiomyopathy, and then during the echo, this is what we found. And the advice to her was to go and get reviewed by her doctor, who then refer her to see a cardiothoracic surgeon for possible management on the way forward. But she didn't seem to buy into the idea. So someone like that, how do you convince her to go and get properly sorted out by cardiologists and cardiothoracic specialists with such a diagnosis?
Thank you very much.
Thank you. So Dr. Jan will answer the questions, please.
Okay. So we can use, it's safe to use the beta-1 selective blockers in patients. So the cardioselective beta blockers. So bisoprolol is very safe for those patients. So in those whose blood pressure is not too low, you can initiate bisoprolol in them. Metoprolol can also use in those patients. Carvedilol should be avoided, and and atenolol. So bisoprolol, metoprolol, they're the preferred drugs for these patients. And then in terms of the second question, once the patient has a peripartum cardiomyopathy, she's very high risk. And you need to let her know that she can go into heart failure if she's not careful. And that could mean the end of the pregnancy, even her life. So you need to let her know how high the risk is, especially around the peripartum period, the time immediate or early postpartum period. So delivery and the management right after delivery is crucial. So you need to let her know that she can lose her life. That way she'll get a bit frightened and she will seek help. You also tell them that you don't want a baby without a mother. It's the worst thing to have a child in the world without a mother. The mother is very important to the child. So when you tell her those things, she'll see the importance of seeking help, at least with a cardiologist, for follow-up.
Thank you. Thank you so much, Dr. Jan. And just in relation to the last question, I realize that most of these things tend to be mindset and situational issues. And I think more and more, one of the things that we can do as clinicians is to engage clinical psychologists, because sometimes you don't have the time in clinic. The next patient is waiting at the door, and the next patient, and the next patient. And if we engage our clinical psychologists, they are also great in making our patients understand the need for them to seek prompt and relevant intervention. Thank you very much, everyone. Thank you, faculty, for answering our questions. And let's just appreciate them once more. Thank you. I'll hand over to Dr. Lambert.
Yes, thank you very much. Thank you very much. So I think officially the session is closed, and we shall just restructure into our main AGSM for the business meeting aspect of the program. So at this point, officially, I need to say that the workshop and ECG slated for this afternoon have been called off. Instead, there were video recordings of what happened yesterday, both ECG and echo. So these will be shared with all participants whilst they go through the online paperwork to access their MDC accreditation. So everyone here would have access to those video recordings for the workshop. So officially, the meeting for non-GSE members has come to an end. And from this juncture onwards, it's going to be those who are members of the Ghanaian Society of Cardiology as we go into our business meeting. Thank you very much for your participation. Yeah, so before that starts, lunch is also ready. So I think we can go take our lunch, reconvene, and then our business meeting will take off. Lunch. Yes, 1:30.
Once daily Forxiga, dapagliflozin, for patients with CKD with or without type 2 diabetes. In patients with CKD, increased pressure inside the glomerulus can lead to a decline in kidney function. Forxiga slows kidney function decline by reducing intraglomerular pressure. Forxiga helps to lower pressure by reducing blood flow into the glomerulus. This renal benefit is not dependent on the blood glucose lowering effect of Forxiga and is not limited to patients with diabetes. The Forxiga mechanism of action is complementary to that of ACE inhibitors and ARBs, which increase blood flow out of the glomerulus. Treating with Forxiga can help slow the composite of declining kidney function, end-stage kidney disease, and renal or CV death in comparison to placebo. In addition, Forxiga reduced the risk of death from any cause versus placebo.
This is for scientists and those who believe in the potential of science. It starts with curiosity, a surprise in the pattern, an obstacle that can't be explained. Step by step by step, they challenge, explore, and unlock the unknown, fueled by imagination, alone and with others, repeating an experiment 1,000 times to have the chance to get it right. Once, but for forever. Making brave choices, choosing to push the boundaries, and choosing again and again to be led by science. In everyday decisions, everyday interactions, no matter where they are. Because putting science at the center of everything is the best way to understand and transform disease. The best way to change people's lives. This is why we believe in what science can do.
once daily Forxiga, dapagliflozin, for patients with CKD with or without type 2 diabetes. In patients with CKD, increased pressure inside the glomerulus can lead to a decline in kidney function. Forxiga slows kidney function decline by reducing intraglomerular pressure. Forxiga helps to lower pressure by reducing blood flow into the glomerulus. This renal benefit is not dependent on the blood glucose lowering effect of Forxiga and is not limited to patients with diabetes. The Forxiga mechanism of action is complementary to that of ACE inhibitors and ARBs, which increase blood flow out of the glomerulus. Treating with Forxiga can help slow the composite of declining kidney function, end-stage kidney disease, and renal or CV death in comparison to placebo. In addition, Forxiga reduced the risk of death from any cause versus placebo.
This is for scientists and those who believe in the potential of science. It starts with curiosity, a surprise in the pattern, an obstacle that can't be explained. Step by step by step, they challenge, explore, and unlock the unknown, fueled by imagination, alone and with others, repeating an experiment 1,000 times to have the chance to get it right. Once, but for forever. Making brave choices, choosing to push the boundaries, and choosing again and again to be led by science. In everyday decisions, everyday interactions, no matter where they are. Because putting science at the center of everything is the best way to understand and transform disease. The best way to change people's lives. This is why we believe in what science can do.
Once daily Forxiga, dapagliflozin, for patients with CKD with or without type 2 diabetes. In patients with CKD, increased pressure inside the glomerulus can lead to a decline in kidney function. Forxiga slows kidney function decline by reducing intraglomerular pressure. Forxiga helps to lower pressure by reducing blood flow into the glomerulus. This renal benefit is not dependent on the blood glucose lowering effect of Forxiga and is not limited to patients with diabetes. The Forxiga mechanism of action is complementary to that of ACE inhibitors and ARBs, which increase blood flow out of the glomerulus. Treating with Forxiga can help slow the composite of declining kidney function, end-stage kidney disease, and renal or CV death in comparison to placebo. In addition, Forxiga reduced the risk of death from any cause versus placebo.